First up is going to be the impact of an emergency triage assessment and treatment based triage program in pediatric emergency department of a Guatemalan public hospital, presented by Heather Crouse from Baylor College of Medicine, Houston, Texas. And I apologize, the abstract in the program is not her abstract, in fact, which is a shame because it was a really fantastic abstract, but it is available online. So if you'd like to read her abstract, it is online.
Good morning. It is a pleasure to be here. I know when I was going through medical school, there were only a few of us interested in international health at the time. It wasn't even global health. So to see so many people here, it's really, it's a lot of fun. So let's begin. The role of pediatric emergency medicine in the care of sick children is crucial. We know that recognition and stabilization of acutely ill children improves outcomes. However, many healthcare personnel in developing countries are ill-equipped to do this for many reasons. And as a result, severely ill children often experience significant delay in the institution of potentially life-saving treatment. Interventions to improve pediatric emergency care, including the introduction of triage training and process, use of clinical practice guidelines, and supervision and monitoring of patients, clearly lead to a reduction in mortality for acutely ill children. So what is ETAT? The Emergency Triage Assessment and Treatment, or ETAT guidelines, were developed by the WHO as part of an integrated management of childhood illnesses strategy to promote improved assessment, triage, and initial management of acutely ill children in resource-limited settings. It was based on standard pediatric emergency courses like PALS, Pediatric Advanced Life Savings, and was developed by a consensus of experts who practiced in resource-limited settings. The tool was validated in Brazil and Malawi using expert physicians as the gold standard, and it has been implemented and published to date in Malawi, Kenya, and Lesotho. ETAT-based triage systems have improved pediatric outcomes in Africa, but really there was no data for Latin America. So how did all this start? We recognized the need. The WHO had produced basic participant and facilitator manuals, but a lack of robust educational materials and availability only in English were significant barriers to creating locally sustainable programs. We had an opportunity to develop a project in Lesotho in coordination with BPI in 2007. So there we developed supplemental ETAT educational materials, including both didactic and hands-on training, to ensure a locally relevant program. So now we meaning many partners from Texas Children's, Baylor, and other institutions, which we'll talk about in a little bit, we had this enhanced ETAT curriculum, and we knew Latin America could use it. Beginning in 2009, we collaborated with multiple local and regional institutions and agencies to adapt the ETAT curriculum that we had developed in Africa to make it locally relevant for Latin America. The materials were translated into Spanish, of course. The name changed. And it's very long, so I'm not going to take up those seconds. And the content modified to reflect local healthcare systems and needs. The curriculum was validated and piloted in both Guatemala and Nicaragua prior to finalization. So global partnerships are locally driven, long-term, and sustainable. We understand that in order to create a large-scale project, there must be collaboration between the US-based group, an in-country partner who is at the center of the project, really driving the initiative, the Ministry of Health, and regional policy advisors like the Pan American Health Organization, or PAHO. We look for a pairing of resources and needs within each group. I will present our model for partnership with ETAT in Guatemala. On one hand, we have Texas Children's, who had ETAT expertise, quality training materials, institutional leadership, and infrastructure, but we were really looking for a site to implement the project in Latin America. We were introduced to Hospital Nacional Pedro de Betancourt through colleagues, and during a site assessment to the hospital, they defined the development of a triage process as a priority for their institution, and they were noted to have a robust clinical site, educational infrastructure. They were really ready to take on such a project. We were able to engage the in-country Ministry of Health from the beginning of the project. They have important access to country norms and are essential partners for developing programs locally and in the region. And we hoped, or in the region, and scaling up in Guatemala. And finally, PAHO. With its diverse experience and influence locally, we really hoped that they might need ETAT content experts and educational materials in order to really launch the project on a large scale. So before moving on, I'd like to talk about the setting for this project and really showcase our in-country partner. Pedro Betancourt is a secondary level public referral hospital in Antigua, Guatemala with committed leadership by Dr. Miguel Soto. He's served in the position over 20 years in a non-political position. He has no plans on leaving anytime soon. They have an organized infrastructure with a capacity of energetic staff, ample pediatric volume, and they have a history of doing some pretty amazing things like developing the first certified human milk bank in Latin America and many other educational initiatives. So they had infrastructure. But most importantly, they identified the development of a triage training program as a priority for them. And in global health, you have to constantly remind yourself that it's not about you, it's about them. And everything about how you really design the project and the partnership has to reinforce that. So using our enhanced ETAC curriculum, a locally led, high quality and effective training program was implemented at Pedro Betancourt starting in May 2010. Now, these trainings have been shown to improve pediatric assessment skills, but the most practical application of these skills is the development of a formal triage process. So once 80% of pediatric personnel at Pedro Betancourt had been trained in ETAT, healthcare workers collaborated with TCH to develop, implement, and evaluate the impact of an ETAT-based triage process in their pediatric emergency department as part of an institutional quality improvement project. So though the remainder of the presentation is really going to focus on the evaluation of this project, first I just want to give you a little bit of background about how the process was developed and implemented. So most healthcare facilities in the developing world don't have a formal triage system, which is really a shame. I mean, it's low cost, it's easy to do, but really doesn't exist. So patients are seen in the order that they present. So you really have this huge line. I know that Marie and Saeed, you can remember the queues. I mean, in Malawi, they're insane. You know, hundreds of kids. So if you're the sickest child, you're at the back of the line. You may be dead before you can actually get to medical attention. So ETAT-based triage allows us to, within 30 seconds to 1 minute, and only the use of a physical exam, no fancy machines needed, to categorize patients into one of 3 triage categories. After observing patient flow in the PD emergency department during a pilot study, a multidisciplinary team, this is nurses, physicians, residents, TCH, we developed this patient flow algorithm for their institution. So just very briefly, patients come in, they are basically divided into 3 groups. You are emergency, priority, or non-urgent. If you're an emergency patient, you're taken right to a shock room. Treatment is started at that moment. If you're priority, if there's a room available, you're put into the room to start treatment. If not, you go to the main waiting room, but your chart is put on top of the other chart, so it's prioritized accordingly. If you're non-urgent, I really liked this because it looked at the flow in the resources for the hospital. If you came in non-urgent between the hours of 7 a.m. and 11 a.m., you were actually sent over to external consults just to see a general pediatrician. I wish we actually did that in our institution more, so I didn't have to see all the ear infections, but we don't. If patients were received out of those hours or if they had need for oral rehydration, they stay in the emergency room, but they wait to be seen in the order that they're seen. So this is the algorithm. The group designed a low-cost triage stamp to be put on all patient charts on arrival. Posters of this triage algorithm in Spanish were placed on the walls of the ED and outpatient clinic. And then videos for patient families describing the new triage system are in production. You can imagine why this is important. I mean, patients are like, wait, my kid got here first and now you're taking this kid back. So they really wanted to explain to the population what this new triage system was. But how do we really know if the triage process is helping? So as we discussed earlier, the initial ETAT tool was validated in Brazil and Malawi, where under 5 mortality rates are sky high. So it's not hard to show a decrease in mortality by 40%. But in Latin America, that's not the case. We can't just rely on mortality statistics to show that a project is working or a program is working. So this is a quality improvement study with before and after design. All pediatric patients, which Pedro Betancourt defines as 0 to 13 years old, presenting to their pediatric emergency department from November 2009 through October 2011 were included in the study. Pediatric residents from Pedro Betancourt, these 2 physicians they are an incredible asset and really have been responsible for all of this data. In collaboration with TCH, reviewed a random sample of charts for every 40th patient seen in the emergency department for 1 year pre and 1 year post-intervention. Why every 40th? Basically, it had to be a feasible study. So you can't review 40,000 charts by hand, absolutely impossible. But we also wanted to show statistically significant differences in clinical outcomes. So we calculated a minimum sample size needed, and that came out to every 40th patient. They also analyzed a subset of chart for all acutely ill children, which we identified either by serious diagnosis or by admission to the Pediatric Intensive Care Unit, or the PICU, in the ER logbook. During pre- and post-intervention periods, since outcomes like mortality are more easily gleaned from acutely ill children. Age, gender, triage category, diagnosis, and disposition were noted for all groups. Key local and regional stakeholders that included Texas Children's, Pedro Betancourt, the Ministry of Health, and PAHO collaboratively chose these indicators really to measure. The population demographics, we just wanted to see really what are they seeing, what is the acuity of kids presenting the diagnoses, and then clinical uptake. So the number of charts that actually had a triage category assigned. And then to measure impact, we wanted to know about hospital admission rate, inpatient length of stay, and mortality. I'm not going to really spend too much time on data analysis for this group. What do we found? First, valuable demographic information has been collected. You can see here the distribution of ages, gender, and most frequent diagnoses of patients seen in the pediatric ER. I'd like to point out a few trends. Mean age for the overall group was 3.5 years, but only 1.5 years for the acutely ill children, with a third of them being neonates. Really fits in well with that 40% of the under 5 mortality is neonatal. That's exactly what we're seeing. Shock and malnutrition were diagnosed more frequently in the acutely ill. These are the various level of acuity at presentations. In the random sample, about 3% presented emergently, 47.6% priority, and roughly half non-urgent. You may think, wow, that seems a little bit weird, but to put that in perspective, the non-urgent percentage is roughly comparable to what we see at TCH. About half the kids we see are really not urgent patients. If we look at kids presenting more acutely, over half were emergent, nearly half priority, and about 1% presented non-urgent, which just really shows you there is a need to continually, frequently reevaluate your patients, even in their waiting room, because sometimes they get very sick very quickly.
I'm sorry, we'll have to wrap it up pretty soon.
Okay, give me 2 minutes. Next, Pedro Betancourt's utilizing the new process. A year prior to implementation, there were no triage categories because there wasn't a process. 1 year out, 97.5% of them have charts. So staff is clearly using the new system, but does it help the actual care of children? So part of evaluating an emergency room process, you have to look downstream. What really happens to your patient outcomes later? So when we look at the random sample, overall admission rate decreased by 8.2 to 4.3%. So you're assuming if you can recognize and start treatment early, they have more chance of being able to go home. So you have really diarrhea, moderate dehydration. If you can start the oral rehydration, they may get to go home. But even in those kids that were admitted, they didn't seem to stay as long. So the inpatient length of stay showed a trend downward of 4 to 3 days. For acutely ill children, the PICU admission rate decreased from 46.9 to 24.1%, and that's statistically significant. So again, we're really assuming that through early recognition and management, you're able to stabilize children and really prevent the need for costly intensive care. All of these kids, the acutely ill children, were admitted, but just very similar to the random group, inpatient length of stay seemed to trend downward. It's important to note in this group of acutely ill children, the overall mortality was 9.7%. So you had a 1 in 10 chance of dying if you come in critically ill. So if you present, but the mortality between groups went from 12.4% to 6%, a decrease by about 52%. It's a trend which warrants further investigation. Really, our sample sizes were quite small, so you're really not going to be able to show a true clinical difference in outcomes. There were only 20 deaths of the over 1,200 charts that we reviewed. But in summary, pediatric-specific triage algorithms can be implemented and sustained in resource-limited settings with excellent utility by staff. Significant decreases in admission rate, both overall and to the PICU, and trends towards decreased length of stay and mortality of acutely ill children suggest that ETAP-based triage systems may improve pediatric care in Latin America. This project really is through the work of a variety of partners. I'd like to thank the following people. It's a true collaboration that's made this project possible, and this is a very, very small section of the project as a whole, but our partners really have been incredible.
Unfortunately, we won't have time for questions, but thank you so much.
Yeah, no problem.
Do you want? Yeah. Okay, we'll do one question. We'll go crazy. One question.
I told them it was going to run long. There was no way to do that in 8 minutes. Any questions? Yes. Yeah. Yeah. I try to think about it kind of clinically, and this would be my thought. So to kind of just put a case out there, let's say a kid comes in with moderate dehydration and diarrhea. If you're able to, if the kid doesn't have to sit in the waiting room 4 to 6 hours, and you're able to really start treatment sooner. This kid in the waiting room is going from moderate to severe dehydration. So by the time you get to them, you start treatment, they get admitted to the floor, and it requires several days to really get them stabilized. My thought on this, and it just kind of in speaking to other people that actually do this for a living, is if you can just really get it started sooner, so that kid in the waiting room really starts the oral rehydration, they come in as more of a mild to moderate kind of dehydration, so they're able to go home a little bit quicker because they just haven't progressed while they're waiting in the waiting room. That's kind of my gut feeling on that. And it's with other ED processes, when we look at kind of patient and process outcomes, length of stay usually does kind of decrease. These are, of course, taking out the, severe acute malnutrition. These kids can stay in there for, weeks to months. And we really kind of took out some of that data, but overall kids that have, pneumonia, diarrhea, kind of basic pediatric illnesses, that's kind of what we saw in both groups.
Okay. Thank you so much. Thank you, Dr.
Thanks.
Crouse.
And next up,